everybody. My name is Madeline Pan. I am a second-year medical student from the University of Texas Medical Branch. And as previously mentioned, I will be talking about maternal antiretroviral treatment and development of significant neonatal megaloblastic anemia. So for background information, according to the World Health Organization, at the end of 2022, there were 39 million people globally living with HIV. While HIV can be transmitted via unprotected sexual intercourse, unsafe IV drug use, and blood transfusions, HIV can also be spread from mother to child via vertical transmission and breastfeeding. Prenatal fetal HIV exposure leads to neonatal HIV in almost 1/3 of pregnancies. Since the immune systems of neonates are not fully developed, an HIV infection puts them at greater risk for opportunistic infections, Candida esophagitis, pneumocystis, Girovechi pneumonia, and cancers. According to ACOG, there have been ongoing studies that suggest that providing antiretroviral treatment to HIV-infected pregnant women can result in a much lower risk of vertical transmission, 1 to 2%, if maternal viral loads are kept at 1,000 copies per milliliter or less. Antiretroviral treatments like zidovudine are used in the management and treatment of HIV, as well as the prevention of perinatal HIV transmission. However, zidovudine can lead to neonatal megaloblastic anemia. Sometimes more than one antiretroviral treatment is used if the viral load is still positive with a single antiretroviral treatment. So how does zidovudine suppress HIV? Well, I have included a diagram that includes both mechanisms, but the first way is via DNA blockage. So AZT acts as a thymidine analog, and as you can see, it inhibits this enzyme called thymidylate kinase. And by blocking this enzyme, it inhibits the production of thymidine diphosphate and consequently thymidine triphosphate. By blocking this pathway, it blocks DNA chain elongation from occurring. Another way that zidovudine suppresses HIV is by folate deficiency, as depicted with the pathway on the left. AZT creates reduced amounts of 5,10-methylene tetrahydrofolate available for thymidylate synthesis, which as a result leads to reduced amounts of thymidine monophosphate being produced, which subsequently affects the subsequent byproducts, thymidine diphosphate and thymidine triphosphate. So as you see, it affects the synthesis of the other preliminary parts necessary for DNA production. Moving on to the case presentation, we have a mother who is a G2P1 LC1 mother, arrived at 35 weeks one day due to preterm contractions that began 10 days prior. And just to explain what all these letters mean at the beginning, G stands for gravidity, which is the number of times the uterus has seen a pregnancy regardless of outcomes. And P stands for preterm in this case, and LC stands for living children. So this mother was in her second pregnancy, with the second pregnancy being preterm at 35 weeks, and she has a living child from her first pregnancy. Her wet mound and gonorrhea chlamydia tests were negative, and she was admitted for preterm labor in the setting of di twins. Pregnancy complications include chronic hypertension that was diagnosed 14 years prior, and she was started on labetalol at the beginning of this pregnancy for the chronic hypertension. After starting Triumeq, which is a combination of 3 antiretroviral treatments, Abacavir, dolutegravir, and lamivudine, her HIV viral load was undetectable and her CD4 count was 845. As for the twins, Twins were born via C-section and both required CPAP and surfactant with oxygen at birth due to respiratory distress syndrome, profound metabolic acidosis, and anemia. It is important to note that at birth, their hemoglobin for twin A was 12.4 grams per deciliter, and for twin B was 12.5 grams per deciliter. Both babies' hemoglobins at birth were abnormally low, as for normally, the hemoglobin at birth would be 15 to 22 grams per deciliter. They were admitted to the NICU for prematurity, along with the need for respiratory support and continuous cardiac monitoring. As for final diagnosis and management, infectious disease was consulted and recommended to obtain titers for HIV viral load from the newborns. The titers at birth for twin A were undetectable, and for twin B were reactive but not significantly increased. Both neonates were started on oral zidovudine at 2 milligrams per kilogram twice a day for 2 weeks, and then was increased to 3 milligrams per kilogram for 2 weeks per protocol. Daily labs were ordered for the first 3 days of life, including a complete blood count, complete metabolic count, and bilirubin levels from the serum. At this time, both twins had anemia, so a blood smear was performed to look at the cell types, revealing monocytosis and megaloblastic anemia with nucleated red blood cells. Due to the continuous fall in hemoglobin, both twins received blood transfusions on day 4 of life. Complete blood counts were monitored weekly until completion of zidovudine and ultimately discharged. And on the right, I have a picture of one of the twins' blood smears. And as you can see by the arrow, it indicates a hypersegmented neutrophil, which is indicative of megaloblastic anemia. As a result, the final diagnosis was megaloblastic anemia secondary to antiretroviral treatment in utero. So the take-home message: with the rise of antiretroviral medication, HIV/AIDS is no longer the death sentence that it was thought to be. However, the effects of antiretroviral treatments on pregnancy and infants is still being researched. This case shows Di twins who had differing viral loads and exhibited megaloblastic anemia. While the link between the use of zidovudine in pregnant mothers and megaloblastic anemia in neonates has been previously documented, neonatal anemia associated with the use of Triumeq has not been documented in the literature. Given low hemoglobin levels within the first few days of life, anemia in this case was attributed to the maternal use of NTRI with lamivudine, as it can cross the placenta. As a result, health professionals need to be cognizant of this potential side effect of Triumeq when treating pregnant mothers with HIV and carefully monitor the neonate's anemia. And these are my references, and that wraps up my presentation. Thank you.
Thank you. That was a wonderful presentation. I do have a question from the chat. Are there other potential causes of anemia with this presentation besides the antiretroviral exposure, especially in the setting of dizygotic twins, and how were these ruled out?
Yes, that's a good question. So, of course, like I mentioned earlier, zidovudine is known in the literature to cause megaloblastic anemia, and it was prescribed to the newborns as a result of being born to a HIV pregnant mother. But one reason we were able to rule out the possibility of zidovudine causing the megaloblastic anemia was because the mother was given Triumeq, which is a combination of 3 antiretroviral treatments, none of them being zidovudine, and already the hemoglobin at birth was 12.4 and 12.5, which is already indicative of an anemia happening. Of course, and in previous cases with zidovudine, neonates are born with anemia, yes, but it doesn't get to the extent where they require blood transfusions. But because on day 4, for twin A, it was 11.6, and for twin B, it had dropped to 10.1. It was a significant drop progressively throughout just their course of life that we kind of thought that it was not, it was the lamivudine just because it can cross the placenta.